Welcome back to Hot Flashes and Cool Topics. Today we have on someone who has been on the show from season 1, which feels like so long ago, Dr. Heather Hirsch. Welcome again to the show.
Well, it's so great to be back. And yes, I remember recording that in the pandemic in my basement, trying to get away from my family.
I think
Yes.
you even went in your car at one point. I think you
Yeah.
did. Yeah.
Yeah.
And that's just how it goes, you
How
know?
it went. That's how it went.
It's
Yes.
so amazing what we will do to get the taping done right and just have like 10 minutes of quiet. But since then, you have been so busy. I can't even believe that you managed to have another child in the mix of how busy you are. So
I know.
congratulations
Yeah.
on the
Thank
new
you.
baby. And you are a menopause expert. One of the things that I really appreciate that you do is your social media platforms. And we're going to talk about the fact that you are the chief of clinical quality and medical advisor at Midi, and which is a new position for you. So that we're excited to learn all about that. And we're going to talk about a few different menopausal issues. But I wanted to start the conversation with the fact that you have really created a platform on social media answering questions for women about menopause. And I think a lot of our listeners would really appreciate knowing more about that because it's so informative.
Oh, well, thank you. I started on Instagram. I remember May 1st, 2017 was the first time I ever posted on social media. I thought everyone should know this. And I didn't realize how much it took to create a really evolving and up-to-date social media platform. And one of the things I will say that really fuels me is the audience and having such amazing audience engagement and comments and feedback. It continues to fuel the next thing that I want to post about, and the next thing that I want to post about. And so I think one of the things is the community building aspect has been really, really wonderful, and truly the community feel and the vibes and the questions fuels a lot of the content that I put out there, or the myths that I want to deconstruct, or the lab tests that so many people just don't understand. And it takes a long time to grow that type of community, but that investment was really worth it, because now I have a community that I can go to say, vote on what you want me to do a YouTube or a podcast on. And they give me thousands of ideas. And it really kind of now sort of in a way fuels itself or runs itself. And I really show up for what my audience is really looking for. And there's so many other ways to talk about the analytics or how to do research and, all of those things. But the truth of the matter is it's really giving people the information that they continually keep asking you in a way that feels authentic and genuine. And that's what has worked so far.
It's so great that they have a doctor that will answer these questions, because even if they wanted to go to their own doctor, they have to make an appointment. They're not going to get in for weeks and weeks. And just to be able to have someone that can answer these questions, that is a menopause expert. And, I know, but Colleen, when you and I were going through perimenopause, which for you wasn't so long ago, Colleen, but
Yes.
for me, it was like 10 years ago or more. And I didn't know what was going on. And I didn't have that on Instagram. I think
Right.
Instagram was pretty new, and
I was going to say,
Facebook.
did we have
Did we have it? I think it was
She's-
pretty new. But Facebook, I wouldn't have dreamed of asking that question on Facebook. And now it's so nice that there is someone like you available out there to help women. And I'm just so glad that maybe they don't have to go through what we did, and it's just going to get better and better for people.
I think you hit on a really important topic here, which is we're seeing a lot more discourse. We're seeing a lot more dialogue and conversation and asking questions that even 10 years ago was really taboo and no good place to go. And so a lot of also, I think what I have come to do is really help people understand that what they're going through is normal, and that these are processes that are physiologic. And I think that's such an important part of the recipe that has helped to make my social media successful.
And I think that you answer questions that everyone is thinking. But I would ask you, like, what are probably one or two of the most common questions you get from women going through perimenopause?
I always get, Dr. Hirsch, is this blank symptom a part of perimenopause? I get that in my DMs everywhere, and then I hear people asking it to each other in the comments, or, if I go on Facebook and go into actually different people's groups, not just mine, is this what to expect? But people ask me in my DMs all the time, is this normal? Is this normal? Is this normal? There's so much validation of symptoms because I think it's been so under researched and so undertreated and so misdiagnosed and so mismanaged for so many years that you have women going to see dermatologists and sleep doctors and endocrinologists, all to find out that their symptom actually was or could be related to a hormonal change.
Mm-hmm. What are some things that you find that happen to a lot of patients before they come to you that have gone through these symptoms and, like you said, they're being sent here or there? What are some common treatments that have been prescribed to them? And what are some things that maybe didn't necessarily help them?
Antidepressants are usually the first line in terms of medications that women will get. And I want to really take a cautious line here in that, I don't think antidepressants are bad. I don't think actually any medicine is bad or good. But the truth of the matter is that most women are offered SSRIs or SNRIs, antidepressants. And they're offered this for a multitude of reasons. For menopause, and doctors think that SSRIs are first line. Hint, they're not. Hormone therapy is the only FDA-approved medication to prevent and to relieve vasomotor symptoms and the other symptoms of menopause. So SSRIs are not first line. In fact, they're off-label. They're not actually FDA-approved for menopausal care. But antidepressants are what I usually see. So it's either because their doctor wanted to prescribe that instead of hormone therapy, or because their doctor mismanaged their insomnia as anxiety, or their menopause as anxiety, or their whatever it may be, ruminating tendencies, fatigue, or whatever it might be, to some kind of what we'd consider a mental illness or a mood disorder, and why you would treat with an SSRI. So SSRI is probably 1, 2, and 3. But I've seen all sorts of other things be prescribed, but SSRI is going to take the cake on that.
Mm-hmm. And that's what happened to me, which listeners have heard that over and over, but that is what happened to me.
But it's frustrating.
It's frustrating. Yeah.
You have recently started a position as Chief of Clinical Quality and Medical Advisor at Midi Health. And one of the things, I looked on the website, and one of the first statistics it said was that 80% of OBGYNs are untrained in menopause, which unfortunately, Bridget and I hear time and time again. So number one, what exactly is the Chief of Clinical Quality? And 2, why did you feel the need to go over to Midi? What are they doing and how are they helping women in menopause?
Yeah, great question. As the Chief of Clinical Quality, I am really in charge of the quality of clinical guidance given. And so really essentially that means I am helping to train our nurse practitioners and our clinicians who are going to be seeing patients and review charts with them and continue to do sort of their continuing, what we would call like their continuing education, help them with efficiency as well, which is kind of like the back end of seeing patients and being able to be quick so that you can see patients, and develop protocols and develop strategies that I can help put in place to help them really do all of that, right? How do I package myself, or, give someone all the knowledge I have that it took me years to learn in a short amount of time. So that is what I'm charged with doing. And me, myself, I'll be seeing patients as well as teaching and training the clinicians and working on creating more protocols. And which is our way of sort of saying protocol is really a way of saying, whether you saw, Nurse Colleen or Nurse Bridget, that there's some standard there where you would hopefully end up, not that they don't have personalities and that there's not more than one way, but hopefully the patient would end up at the sort of a very similar care plan. So that's kind of what the idea of those protocols are. And I was wanting to find a way to be able to really to be able to scale menopausal care, and to be able to give care to women that didn't happen to just be geographically lucky in Boston. And, it was always this push-pull on my heart. I was so happy to bring the clinic to Boston, just like I was so happy before that to bring the clinic to Ohio and treat these women in these areas of like Google Maps, right? But as I have a social media presence, as you guys talked about at the beginning, as people DM me all these things, they're not just in Boston, they're not just in Ohio, and quite frankly, they're not just in the United States. And so I would love if I would be able to make an impact on so many people's lives. And if that means training other people to be able to follow similar protocols and prescribe similar medications and to provide educational content to patients in ways that I alone can't do, that was something I was really excited to be able to do.
Yeah, I was listening to your podcast with the CEO of Midi.
Yeah.
And what I found so neat about Midi was it's not just concierge medicine. So you're really trying to reach women of every demographic. It's not just to reach women that have enough money to pay for this care that isn't necessarily covered by insurance. Can you describe how Midi could reach women that maybe don't have that luxury of being able to pay out of pocket for things?
Right. So the going the insurance route is the harder route because, oh my gosh, like every state you have to, and every you have to it's paperwork. It's a lot of paperwork, but the reason to do so is it allows people to use their insurance, which hopefully they already have. So it is you can cash pay if you're essentially like if you're in a place that we aren't yet there, but you're really want to look for care or get a jump start. But by taking insurance, this is going to allow so many other people to have access to something where otherwise if you didn't have a doctor near you, you would have to travel or you would have to wait on really, really, really long wait lists or whatever it might be. And so hopefully there's not just one insurance, but multiple ways where we can increase access to care or timely care, right? Because it would pain me when my staff would tell me, hey, Dr. Hirsch, just so you know, your next new visit is in 9 months. And can you please, what do you want me to do with these 5 patients who are begging to get in? Is there any way you can see them sooner? It was just so, it felt like a lot of weight on my shoulders because it was so unfair for the patient, yet I couldn't work any harder either, or else I would crumple too. And then
Yeah, the
so
quality would be gone. Yeah, if you were
there you have
doing
it.
that.
There you have it.
Yeah.
Do you think that women are starting to hear more about the telehealth market for menopause and how it really can be a very effective way for them to receive treatment?
I think so. I think so. Certainly, luckily the pandemic kind of got us all used to telemedicine for better or for worse. And because I think now, at least, except for probably my parents, and they're in their 70s, but at least probably everyone has either had a telemedicine visit or like knows what telemedicine is because everyone's doing it. And particularly our generation, even, our I always get this mixed up, right? Our Gen Zers. I'm a millennial. Then it goes Gen X, then Gen Z. I don't
We're,
even.
Well,
we're
you're
before
Gen X.
that. So.
We're Gen X. You're a millennial. They're Gen.
Yeah, okay. Yeah.
I think it does go.
I
I think it does go millennial before.
We must research this and find the answer.
Right. But like the younger generation, in their 20s and 30s, like the telemedicine for them is like this wonderful thing, and they're so apt to use it and make it. And menopause is one of those areas where a lot of actually primarily what I'm doing is learning about you and consulting and helping you make a decision. And so it lends itself beautifully to telemedicine.
Can you talk a little bit about women come to us and they'll say, can you explain the difference between HRT, bioidenticals, patch, cream? They're so overwhelmed by information. They don't know, well, what's going to work for me?
Right. this is also, I guess, another big important question. And I kind of have my elevator pitch of this. So, believe it or not, bioidentical is a made up slang marketing term. Yes, folks, it's not a real thing. There is no pharmaceutical grade bioidentical anything. And it is the most genius marketing term because doesn't it just sound great? Like it's bio and it's identical to me. Bioidentical, if you replace that word for estradiol, you're going to win every time. So forget the word bioidentical because it is a slang term. And even has a position statement on this. So bioidentical means estradiol. Estradiol itself compared to premerin or conjugated equine estrogen. Estradiol is a more plant-based estrogen that looks chemically similar, not exact, but is as close as it can to what our body endogenously would make. Now, the difference is that even though we can say it's plant-based, it's still made in a lab. It doesn't come from, yams that we grind up and then put some magic dust on and then put your DNA in, right? There's this imaginary thing that we've created that bioidentical is this magical safe component, and it's estradiol that's made in a lab. That's it. It's estradiol. So whether estradiol is cream, whether estradiol comes from CVS, meaning it's FDA approved, or it's compounded, meaning it's not FDA approved, you can get estradiol either way. What you really want is FDA approved hormone therapy first and foremost. And you can get bioidentical. And if you are listening, listeners, I've got air quotes, bioidentical estradiol that's FDA approved. And all you want to look on your box is say, it says the main ingredient is estradiol. Now, premerin or conjugated equine estrogen comes from horses. Most people know that. And whether you think that that is terrible, agree, ethical or not the point, but it's not bioidentical, right? Because it's not naturally derived. It comes from animals. So conjugated equine estrogens or conjugated estrogens, particularly that's this main classification, are not sort of this more plant-based approach. Now, I'm also going to let you in on something really, really, really interesting, right? People think bioidentical, always say bioidentical is better, but the safety of estradiol, the safety of hormone therapy in general, actually all stems from the research we have from premerin from the WHI. And premerin without a progesterone in the WHI statistically significantly decreased the risk of breast cancer. And so, people always say, well, isn't premerin the bad stuff? And I'm like, well, I mean, now, most people prefer bioidentical because we have slammed that word down people's throats. And I'm not against that at all. But it is really interesting when you think about actually the history and the term and how it is used and how then is actually quite confusing. But then women are marketed this false term, isn't it?
It is
kind of predatory.
Yeah.
Yes,
It's interesting. You're saying, I think I saw something today. I don't even know where I saw it, somewhere on social media, or I don't even know if it's TikTok or Instagram, but it was a chart saying what were the bad ones and the good ones. And they had premerin, the thumbs down. And I can't remember what else they had thumbs down. They did not have, they had like estradiol, which you were saying, with a thumbs up, with a patch or whatever. And now I'm thinking, I don't even know what the research behind that was. Yeah.
That's the scary part is that people are posting stuff.
Yeah. And the truth of the matter is that, to not take it too deep in the woods, but when it comes to progesterone, what bioidentical also typically refers to is micronized natural progesterone or prometrium compared to medroxyprogesterone acetate or progesterones that are not made as much from natural products versus progesterones that are made more from natural products. And the progesterones maybe differ a little bit more than the estrogens. But all in all, I'm going to tell you what I tell all my patients. If I was on a deserted island and all that was there was prempro, I would happily take it.
Okay. Yeah, because it's starting to get a bad name. It was the only option for a while, but it's really starting to get a bad name.
Yeah.
So I don't know. I think the thing about passing through the liver, things like that, is that a big concern, or do you find that to be a big concern?
It's not a big concern unless a patient has some pre-existing comorbidities. And there are some cases where certainly transdermal definitely is better. Diabetes, dyslipidemia, bariatric surgery, any type of malabsorption issue. Doesn't apply to everyone. And so this is sort of where it kind of gets into an individualized kind of approach is so, so helpful for women when they're making decisions, but and that's why out of these sort of posts, like what's thumbs up and what's thumbs down, taken out of context, is they're just add more fuel to the confusing fire. So I have a woman came to me, she's like, I'm doing so good on this premerin or this prempro, but everyone tells me it's dangerous. Like, should I switch? And so I say, let's talk about why that idea comes from and how dangerous is it really? It's not, are there things that are slightly better? Maybe. Is it worth it? It's up to you,
Mhm.
And so I think that, don't get me wrong. See, you got me down a rabbit hole. I said I was going to go down. I love individualizing hormone therapy with women. That's my jam. I love talking about your dose and your route and your formulation, which is, bioidentical versus not bioidentical. But I guess what I'm trying to say is you're right. With so much mixed news out there from people who are not necessarily experts, it is a scary world, which is why I wrote a book.
Yeah, which
which
we're
is
very
coming
excited
out
about.
next
Yes.
year, and
Yes.
we are actually going to
Yes.
have you back on to talk all
Yeah,
about
to talk
it,
about it.
we're
Unlocking your
excited.
menopause type. Very excited. Yes.
Which is
Yeah.
great. Since we're on the road of controversial medications and things that women can take, I have heard a lot of things about Ozempic recently and some other diabetic medications that women are using for weight loss. But then I watched your TikTok and I was like, well, I'd rather go to the experts like you and know exactly what's happening. Can you talk a little bit about that?
Yeah, sure. So I think Ozempic probably catches the majority of its controversy around its use. I'm not going to say this probably in the best, most thoughtful way, but it's essentially about abusing a medication for women maybe who don't qualify as obese. For maybe we think about I think about on TikTok, Kim Kardashian using Ozempic to fit into her Marilyn Monroe dress, right? Speculation, of course, but doesn't seem all that unplausible. And so I think a lot of the controversy, at least for me, lies in the idea of, are people going to use this medication for evil and not good? Because I think using it for weight loss, specifically for people with comorbidities or for obese, is amazing. Amazing. Obesity is a chronic condition, not unlike COPD or cancer or asthma or chronic back pain. And to treat obesity and give you a better quality of life and to reduce the chronic disease burden is astronomically important. And I've prescribed Ozempic for many of my patients. And of course, I'm a menopause consultant, so I'm usually first doing their menopause and getting them on their hormone therapy and making sure they're sleeping and making sure their diet is good and they don't have any other anxiety and depression or binge eating. And then if they say, look, I'm still, 40 pounds overweight and by my height and stature, it really can help. It's a chronic medication, so it's probably something that you are going to really need more long-term than short-term. But I think where the main controversy, at least in my heart, lies is, what about the patient that wants to drop 5 pounds before her wedding? What about the patient who can't lose that stubborn last 10 pounds? Who is the ethical weight police to say what's right and what's wrong? And I would not put myself on that list necessarily, because that's a really big social thing, because it is one of those things that are so two-sided of, we always tell, women are always, expected to be I open TikTok and it's always like, how to make this food, how to eat this many calories, blah, 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 blah. You're not even looking for the information, but you're flooded with it. So now, should you use a medication to get what you want? But also, is it fair to say, well, if you're 10 pounds overweight, just try harder?
Yeah.
Exactly. And I know when you
Yeah.
posted what you posted on TikTok, you posted a one right after going, whoa, wait a second. Like you must have gotten bombarded with opinions from everybody. What happened there?
Well, there are definitely opinions on, it's just because, society shouldn't turn to medicine. Society shouldn't turn to big pharma, right? Big pharma is just the root of all evil. I'm a clinician. So I'm a clinician like the majority of clinicians who've worked at academic centers who we don't make money prescribing medications. We get nothing out of it other than helping our patients, right? And so you got a lot of people saying, oh, this is promoting big pharma, or this is promoting unhealthy lifestyles, this is promoting unrealistic, unobtainable things. What about, how much this costs? This costs, that was another thing, right? Oh, this costs so much. Only such and such people can afford this. So it opens a lot of can of worms that I'm not saying people aren't wrong about. But what we do know about weight, to be quite honest, is that it is not just willpower. It is not just willpower. And it's garbage that we tell, particularly women, that it's just willpower, that just stick to your caloric,
intake and everything. Yeah.
And maintain your caloric deficiency
and
all
work out more. Yeah. Yeah.
It's not just that.
Yeah.
And so a lot of the pushback is on, our medications are always the right answer. And the answer to that, to be honest, is it really depends upon the patient's situation, and the relationship that the shared decision making between them and the clinician and their other chronic diseases. And yes, sometimes it does come down to coverage and can you afford this? But there's a million different examples I have of patients who have used this kind of medication in all different types of scenarios. And so it is, you're right, Colleen. It's kind of controversial.
I'm just curious about, well, first of all, weight, not only physically being obese, it is hard on everything else, but mentally, if your mental health, you can be depressed about it. You can really feel bad. So it affects your mental health. And then I'm curious, are there any side effects that are really scary, with taking this?
This is true. And I will tell you, I had a patient for whom she was that patient that needed to lose 15 pounds. And she had been with me for a year. And she could not, and she was a professional and had sought mental help and had done everything. And we decided to start her on the lowest dose, right? The patient is suffering so much from this. And she was under physician guidance when we did this and et cetera. And so these are all really important points, right? So side effects, it can make you feel nauseous at first. You can feel a little woozy, lightheaded, dizzy. And because of those symptoms, you're supposed to start the patient, and I always do, on the very lowest dose for a month. And if you can't tolerate that, it's not worth it. It is not worth you feeling like you're going to trip and fall or have an accident. And so as long as, at the lowest dose, you can tolerate those side effects, or they've kind of worked their way out of their system, then you can kind of slowly go up on the dose.
This sounds so interesting. Also, it's originally for diabetes. Is that the purpose? Could it prevent?
Yes.
Because you know how people are that, oh, you're borderline, you get your numbers and you're borderline, or type 2 diabetes. Can it be preventative for that?
So we have no data to show that it can. But this is an excellent question, right? Because your brain is like, what if, I bet your hypothesis would be true. But in order to actually say I know the answer to that, we would have to have women, pre-diabetics, take the medication compared to a woman pre-diabetic who say follow a good healthy diet with exercise to see if they didn't. However, on this topic, I will say we know that hormone therapy reduces the diagnosis of diabetes. And this is a really interesting point because it gets muffled so much under a lot of the weight of everything when talking about hormone therapy, but this is really true. And you know where we know this? the WHI and prempro.
Oh, really?
All roads
Really?
lead back.
All roads lead back to the
Big old
WHI.
circle, yeah.
But, prempro and premerin both decreased the diagnoses of diabetes in women who took it in the WHI compared to placebo.
Huh.
And so it probably works differently by controlling insulin resistance versus Ozempic slows gut digestion and reduces your appetite. However, your thought, Bridget, is that if you used it in pre-diabetes and your weight just stayed lower and you didn't ever get up to the point where your pancreas was kind of just getting more insulin resistant, you might not have diabetes. So it's also fascinating, guys. It really, really is. And
Wow.
I have a big mouth. I could talk forever.
Well, no. And I think
It's fascinating. Yeah.
It really shows the importance of talking to a doctor who is educated on the topics and not just going to someone that, well, my friend told me to take Ozempic, so let's give it a shot. Or, you know what I mean? Like really educating yourself through finding the right clinicians.
Yeah.
And I noticed you have a pretty big staff at Midi Health as far as clinicians go.
Yeah, there is 4 docs, there's 4 NPs, and many more coming in to start their training soon. And it's so exciting to see it grow. And I guess it's corny, but I just want a world, or I'll take the United States to start with, where women feel as though they have access to a really knowledgeable and evidence-based doctor to help guide them to the right decision, and that we stop judging women for taking hormone therapy or not taking hormone therapy, because it goes both ways, right? And people just feel really excited about their choice in menopause if they have symptoms on what priorities they have and what they want to treat and how they want to treat it. That's really my pipe dream.
And I think it's wonderful that you're doing the training, because that's the hardest, like you've said, that's the hardest thing, is to find a clinician that has been trained in the menopause world. And so I think that is just fabulous that Midi Health is taking the time to train people to be able to answer these questions.
Yes.
Yeah.
Yes.
So we hinted around a little bit that you have a book coming out next year. And like I said, we're going to have you come on, talk all about it. But what made you want to write a book unlocking? It's called Unlocking Your Menopause Type. What made you want to write a book about unlocking your menopause type?
So the reason I wanted to write this book is I had been seeing patients at the time for about half a decade, and I started to see these specific patterns over and over and over again. At the same time, I always love this idea of this individualization that we've kind of threaded through this episode of, you really need to sit with your doctor to decide based on your history and this and this and this and this and that and your goals, what to pick. And so I thought to myself, oh, I can actually really help tailor treatments, and not just treatment, but lifestyle and ways of thinking based on these 6 different types. And of course, that's not uber personalized, because that would be a doctor's visit, but it can at least help start people see that I see these different types of menopause. And then I thought, what a fun way to also teach menopause, because I bet people are going to want to know, what's my type? What's your type? Right. And, so it's also very inclusive. So the first type is premature menopause. Oh gosh, now I'm going to have to remember my own types in my own book. Premature menopause. I'll give you guys a big clue for your listeners. Premature menopause, sudden menopause, full throttle menopause, mind and mood menopause, lingering menopause, and silent menopause. And you might think that silence kind of like, but there are some women who don't have any symptoms, and because of that, they might miss a lot of important body changes because they don't have any symptoms in menopause. And so those are the six big different types of menopause that I see. And throughout each chapter of the book, I really talk about what causes that kind of type? How can you treat it with hormone therapy if you didn't want to use or you can't use hormone therapy? How can you treat it with lifestyle and supplements? And each of those has just so much depth and breadth in each chapter. The first part of the book really goes through also in a very Heather Hirsch way, what the heck is menopause? What are the big myths and misconceptions? What's the deal with hormone therapy? We answer the bioidentical question. And the last part of the book is this whole like DIY and preparing yourself, to live your best self through the menopause transition. And the DIY part is, if you have a specific symptom, let's say it's breast pain, right? How can you treat that at home? And I give you like 5 or 6 steps to treat each specific symptom at home. So I hope it is really an inclusive book where it's the first book that cancer survivors can go, younger women can go, women without symptoms can go, women with real mood disorders can go, to really see how menopause has impacted their life based on their unique symptoms. And it's also really, really fun to read. I throw in a lot of anecdotes and stories of patients that I've seen and treated. And I hope it's really inspiring and uplifting. Gosh, that sounded really good, didn't it, girls?
Yeah.
We'll cut that piece and just send it to you so you can
use it again. Yeah, but it's pre-order right now because I've checked on Amazon, and so it's in pre-order right now, but I can't wait till it comes out because that'll be really interesting. Just great information for women. We just need more of that. There's just not enough for us. Yes.
I know. Well, thank you so much for helping to bring up the book. I'm so excited about it. I really hope it becomes like a new what to expect when you're expecting kind of
Wouldn't
book,
that be
right?
nice?
Yeah.
And really serve as a really, really nice guidebook. And so I'm really, really, and I am a tough critic of myself, but it came out beyond words. It came out really, really great. And while I'm on the topic, Stacey Colino is the writer who worked with me on this book, and it is the woman who made everything up in my head come out perfectly, beautifully, and fun and whimsical on paper. So I couldn't have written this book without my co-pilot, Stacey Colino.
Well, we look forward to reading it next year and having you back on, and we'll talk about each of the types.
I'm excited.
They're so juicy. They're so juicy. Well, thank you guys. Thank you so much.
Well, thanks for coming on. We appreciate it.
Well, thank you so much for thinking of me, and thank you for having me. And thank you for being a really big, important voice in the discourse on midlife and making midlife really what it should be, the best part of life.
Well, thank you. We appreciate it.